morning. Thank you to the organizer. This, like Dr. Sarupa said in morning, we actually look forward to this U review. So my paper is on sequencing of androgen deprivation, especially the short duration of androgen deprivation with radiotherapy for non-metastatic prostate cancer. It's a sandstorm study, a pooled analysis of 12 randomized trials. So this was published in JCO last year, sometime back. This is a pooled analysis of 12 randomized trials. We know the background that ADT with radiation improves survival. The two main source of the data is from RTOG 9413 and the Canadian 0101 trial. They want to see the optimal sequence as well as relation to the radiation field size, whether we're doing a prostate only or a whole pelvic radiation. Now, in lieu with that, the Amar Kishan study of the individual patient meta-analysis has suggested that addition of ADT, prolongation of ADT with an modern radiation dose increase metastasis-free survival irrespective of the risk group's age and the RT dose given. However, to keep in mind, this has not to do with the prolongation of the neoadjuvant hormone schedule. Based on that, this MARCAP consortium hypothesized that a short-term androgen deprivation, which is 4 to 6 months, and a radiation field size, either doing a prostate only or an whole pelvic radiation, in the concurrent and adjuvant scenario would offer an improved metastasis-free survival. Now here, neoadjuvant means that the hormone has gone 2 or more months before starting the radiation, and concurrent adjuvant schedule means that it is at the time of commencement of radiation. What they excluded from these 12 trials are certain big trials arms where it was purely adjuvant, or more than of the 80% of hormone has gone before the starting, or you don't have data for metastasis-free survival, or the CHIP trial certain arm where they have given non-steroidal anti-androgens. Now the statistical analysis are usual for descriptive and Kaplan-Meier methods, and something we are hearing from morning is IPTW, which is they have checked for ADT sequencing in relation to the outcome. Now, since it's a 12 trials data, they had a lot of patients, close to 7,500 from these 12 trials. The neoadjuvant and concurrent schedules were more as expected because this has been the standard more or less, whereas the concurrent and adjuvant had lesser patients. With median follow-up of more than 10 years with median age of 70 years, the concurrent adjuvant group they have noticed had to have more T stages, higher initial PSAs and high NCCN risk groups, and higher percentages of utilization of whole pelvic radiation. However, there was improved metastasis-free survival in the concurrent adjuvant protocol than the neoadjuvant concurrent protocol. If you see the 10-year estimates, it's around 65% versus 61%. Whereas improved biochemical control also in seen with concurrent adjuvant protocol than with neoadjuvant concurrent protocol. Improved overall survival also seen in this. So all these three parameters were better in the concurrent adjuvant protocol than neoadjuvant concurrent protocols. After the statistical adjustment, except for the overall survivals, all other endpoints were correlating to the radiation field size. So in the whole pelvic, when people are receiving the whole pelvic radiation, the ADT sequencing was not associated with metastasis-free survival. However, for prostate-only radiation and adjuvant concurrent hormone sequencing have shown to improve the MFS. Whereas neoadjuvant concurrent ADT and whole pelvic, when this was the sequence, it has an improved distant metastasis-free benefit. Now, this has not stratified between intermediate and high, and there were a couple of patients of high risk. I'll come to in the shortcomings. So this was the basic characteristics, the baseline characteristics. And if you see in the forest plot, the favoring part of the concurrent adjuvant protocol is for all the parameters related to prostate only or whole pelvic, except for the distant metastasis in whole pelvic radiations. So this is something which is different than what we have been hearing till now. So the authors have concluded and given their points that there is certain amount of interaction between short-term androgen deprivation in relation to the radiation field size, The prostate-only radiation, there is improvement in MFS and overall survival and in a concurrent adjuvant ADT sequencing. Whereas once we do whole pelvic radiation, there's improved distant metastasis-free survival by an neoadjuvant concurrent regimes. Now these are contradicting results to RTOG 9413 and the Canadian data. There are unclear mechanism related to that. This is authors have concluded as well. Maybe the adjuvant ADT causes a protracted radiation-induced tumor cell death, whereas an whole pelvic radiation might eliminate pro-inflammatory lymphocytes. These are all hypothesis generating. Now, they accepted their limitations. There's a lot of heterogeneity. You are trying to pull 12 trials results together. There were not a mandate on a PSMA-based assessment in this, which is in our part of the world been done more routinely than Western world. And neoadjuvant concurrent also has a component of adjuvant duration as well. So you're not sure until you're doing a testosterone level in between that at what point the castration level being reached. And some also have GnRH agonist also being utilized. So there's a conflict in that. And they have only analyzed the short-term androgen deprivations, which may not be ideal for the high-risk cohort. So they have concluded that a concurrent adjuvant ADT short-term sequencing with prostate-only radiation might give you optimal oncological outcome, and probably that can be a standard of care for intermediate risk disease. Now my take on this SWOT from these data, it's a good strain data. You have pooled analysis of 12 randomized trials with a decent follow of large patient numbers. You have short-term androgen deprivation with sequencing of radiation field extent, and probably this is the first ever to report a short-term androgen deprivation and a concurrent adjuvant scenario sequence with better oncologic outcomes. So probably for intermediate risk, especially for the favorable ones, we really don't need to do a neoadjuvant hormone and wait and then do, which has been done in traditional way. However, there are a lot of weaknesses like the heterogeneity of the data, combining intermediate and high risk together. For high risk, this is suboptimal, the short-term androgen deprivation. For high risk, the port as well is suboptimal after the POP-RT data. There are no toxicity data reported on this and no comment on the type of ADT agents used and in relation to achieving the castrate range. Now this also opens window of opportunities, documenting in a prospective evaluation of short-term androgen deprivation in purely intermediate risk and see the sequence between prostate only or whole pelvic. There would be further documentation in the high risk for long term. We'll have a lot of already articles on SBRT and hormone sequencing that will also open opportunities by this, and maybe we can avoid ADT in the favorable intermediate risk. The imminent threats would be relying on an IPD and then changing the practice, and which is somewhat different to the standard of care of neoadjuvant, concurrent and adjuvant ADT as we do. There should be a strict caution on omitting the whole pelvic radiation after the POP-RT data and also the SPORT trial and other datas. And they have again clubbed high risk, so we really don't have a clear answer for short-term androgen deprivation and how come high risk be included. So probably these two would answer these questions in future, one related to ADT with and without whole pelvic radiation, coupling both unfavorable intermediate and high risk in the RTOG 0924, and the pivotal boost trial, which is in 2x2 factorial designs of whole pelvic prostate only with an prostate dominant interprostatic nodule boost with and without. So we'll have to wait for these two probably in the 6th or 7th GU review to get an answer for this. Thank you.